Welcome to Grand Rounds. Dr. Sidebottom is away, so I have the privilege to introduce Dr. Elaine Alpert today. Before I read her introduction, however, I want you to know that Carrie Ann and Mara from the Center for Hope and Healing are at the back of the room, and there are some cards on your table. So the Center for Hope and Healing is for survivors of sexual assault and their loved ones in the Lowell area. So please stop by, say hello, take the card with you. They're going to be a great resource for our patients. Now I'll introduce Dr. Alpert. Dr. Alpert received her medical degree from University of Michigan, completed her internship and residency at Boston City Hospital, and also completed fellowships in internal medicine and rheumatology at Boston University School of Medicine. Dr. Alpert also received her Master's of Public Health from Boston University School of Public Health. Dr. Alpert is an internationally respected scholar and consultant in family violence, sexual assault, and human trafficking. She is the founding chair and current member of the Massachusetts Medical Society Committee on Violence Intervention and Prevention. She has authored numerous additional important articles and guidebooks about family violence, sexual assault, and human trafficking for physicians. Dr. Alpert has received honors and awards from the American Medical Association, the Massachusetts Medical Society, and Futures Without Violence. Too many committee memberships and awards to mention. We are so privileged to have Dr. Alpert with us today. Dr. Alpert.
Thank you. So I had some pretty extensive medical education. What I learned about intimate partner violence and all forms of violence in relationships, I learned from advocates, I learned from patients, I learned from people on the street, I learned from police officers. When I started this work, I didn't have gray hair, and there was very little scholarship in this field in medicine. And so I'm pleased to share with you some of the information that I've accumulated over the course of my career. The base of it and the core of it is really from the advocacy community. And so I'm so glad that two of our advocates, and I hope somebody from the Center, from Alternative House, will be coming as well. I have two things that are on the back table that I'd like you to take. The first is actually a copy of all of my slides. The reason for that is because there are 60 slides on this, and I have about 75 that I'm going to show you. That's ridiculous, okay, for a 45-minute talk, and I know that. And the reason that I've given this, put this all together, is because I wanted to serve as a resource to start an exploration, to inspire people to say, wow, I'm glad I came here because now I am starting to learn about this rather than I know everything I need to know. So forgive me when I say I want to leave this for your reference and move on to the next topic. There's a lot here, and my hope is that we actually can inspire a movement to create a hospital-based program here because you have such wonderful local community resources. The other handout is a 2-pager. It used to be a 3-pager, but thank you for saving paper, Karen, and that throws the titles off. But that's a statewide and national resource list in a condensed form. It doesn't include Alternative House or the Center for Hope and Healing, because that's specific to Lowell. But you have information about those resources out in the back. And the last thing I wanted to show you, and I can pass it around, and if it disappears before the end of the talk, that's fine. There's a really good review article in the New England Journal about intimate partner violence that was published in February 28th, actually, so it's just 2 months old. Now 3, because it's May. So I will actually give this and let it go around. And if it doesn't come back, that's perfectly fine. Okay, so we have a lot to talk about. And my conflict, I have no commercial conflicts or industry conflicts or anything like that. My only conflict is that there's too much to talk about in too little time. So that's, and the Q&A period will last for 50 years, and so that's why I put my email address, ejalpert@massmed.org, at the bottom of the first slide, and it will also be at the end of the presentation as well. I really do encourage questions and dialogue and further exploration. So today, we're going to do a brief overview of intimate partner violence as a healthcare issue, and we're going to talk briefly about identification and response components, focusing on trauma-informed care, routine inquiry. I don't call it screening, I call it routine inquiry. Identification and response. How do you identify situations in your office practice, and what do you do? The connections that we need to make to have good referral and collaboration, and then how you can go further on this in terms of continuing education and leadership. So here's one reasonable definition. A definition is what you define it to be. This is an amalgamation of many other people's definitions, and it's what I use because intimate partner violence or domestic violence is a pattern of coercive behaviors. It's not a single act. It's a pattern, and it's actually a process that's used in a relationship against current or former dating or intimate partners. Violence is one part of that, as we'll see on the spectrum, and I put the physical violence, which is what we usually think about as domestic violence, really towards the end. And this is not ordered by prevalence. This is just ordered by how it might manifest in your office practice. And clearly, threats and acts of intimidation are the most common that I have seen in my practice. We also see threats or attacks on property, pets, or keepsakes. Social control, who you can see, who you can't see, where you can go, why were you there, how much did you spend, where's the receipt, where's my change. There's all kinds of aspects of that. We also need to think about reproductive coercion, emotional degradation, economic control, spiritual abuse, and use and manipulation of children, and sexual assault, in addition to physical violence. So I want us to get out of the black eye model and get into this is more of a spectrum of behaviors that each individual survivor or patient of yours will exhibit differently. Just a little bit about reproductive coercion, because this is actually newer information. Of course, reproductive coercion has been going on as long as domestic violence has been going on, and as long as there has been any attention to contraception or reproductive control. But as an area of scholarship, it's fairly new. It includes not just sexual assault and rape, but also preventing somebody from using contraception or forcing them to use contraception. Somebody else trying to control the reproductive activity of another person, basically. Refusing to use condoms, taking the condoms off without telling the partner, putting a hole in the condoms so that it's an act of control to make somebody have your baby, for example, and on and on. And again, you can read this in your resource materials at your leisure and contact me with any questions. So what makes intimate partner violence different from other kinds of violence? This is not just, did somebody hurt you, or did you get mugged, or did you fall and break a bone? The difference is because this is an ongoing and evolving and dynamic relationship with the perpetrator. Even in a relationship that has been in the past, there is still the ongoing, sometimes contact and sometimes effects of that relationship. It's not a one-time issue. It's ongoing. Almost always there's an emotional attachment to the perpetrator. I think that we can all remember ex-relationships that we've had, hopefully not abusive, but there's still some kind of an emotional connection that you have. You don't start a relationship with somebody, as a business transaction. There's always some kind of an emotional connection, and that always lingers in some form or another. Very often, the survivor is dependent on the perpetrator for economic survival, for housing, for food, for childcare. You may actually share friends. You may share a social network, and this actually becomes a particularly important consideration in the LGBT community, because if you want to leave your batterer, and it's a same-sex batterer, the community is fairly small and people know one another, and your danger could actually increase, and also you don't want to be shunned or stigmatized by your own community. There's a continuum of coercion rather than just isolated events. It's not like something happens and then in between everything's fine. The coercion actually has some kind of a continuum or pattern to it, and on and on. And I'm going to leave the rest of this, again, to your individual reading just because of time. Except for one thing, I do want to actually hit the last 2 points, that the danger may actually increase after leaving. With all other types of violence, the danger actually goes away when you're away from that situation. But in intimate partner violence, very often the danger increases, and most of the attacks and murders and murder-suicides come once the perpetrator understands that the survivor is no longer willing to be controlled. And so it's an ultimate act of control. So the danger often increases after leaving, and the health effects may actually worsen after seeking help. So that you may ask somebody about this, and they may disclose to you, and all of a sudden they seem to get worse, and you wonder, what did I do? Did I do something maybe I shouldn't have asked? No. This is the, finally you're able to talk about it, disclose, be vulnerable to somebody you can trust. And so very often the health effects may worsen before they begin to improve. Now, language is super important. When I have a full-day workshop, which is an advertisement that I would be happy to help organize or come back for, we would, and so here's the spoiler alert, so if you're going to come to a full-day workshop in my brain in the future, don't look at this slide. I would split participants up into small groups, okay, in tables, and I would say, I'm going to give you a word to define and describe, and then we'll talk about it in a little while. So I would have groups of 6 to 8, and I do this pretty commonly, and I would give one half of the audience in small groups the word victim, and then I would give the other half the word survivor. And they wouldn't know what the other one was. They just had one word to describe. And this is an amalgamation of some of the terms that we come up with when people define and describe victim. Defeated, wronged, ashamed, helpless, hurt, things like that. I'm sure you can come up with a few more as well. Even dead. The subset of people who are pondering about the meaning of the word survivor, the words are very different. They almost don't intersect at all. Renewal, resilient, progress, liberated. And for this reason, I'm just pointing out that the language that you use can be really impactful to the person you're caring for. So when you say, are you a victim? People are thinking, oh, are you asking me, am I fragile, am I weak? And I actually had a student who you might even remember, Sarah, so I'm not going to say her name. She once said to me, I had a relationship once with a boyfriend. I'm glad that it didn't continue and that he's gone forever. And I wasn't a victim, but it would have probably gotten there had things progressed much further. And I said the magic 3 words, tell me more. And then she proceeded to give me a whole account of really horrible victimization, including being pushed down the stairs, winding up with a broken ankle and in a coma for 2 weeks. And said, but I'm not a victim of domestic violence. I'm so glad I wasn't the victim. And she's like super smart. She's like 3 times as smart as I think all of us put together. She was amazing. But just the conceptualization of that term can be really, really, really difficult. The other illustration of victim versus survivor and the importance of language is this card that the Center for Hope and Healing has made available to everybody in the back. Is anybody as old as me, and do you remember what this organization used to be called? What?
Greater Lowell Rape Crisis Center?
Yep, Greater Lowell Rape Crisis Center. If that isn't a victim-oriented term, and the leadership there said, you know what, we don't want people feeling like they're victims, we want people to feel like they have hope and healing as soon as they access our services. So that's actually a local living example of the importance of language. All right, so why don't people leave? This is a pretty bad thing, intimate partner violence. Sometimes it's fatal. Very often it produces injury. It produces all kinds of mental health effects. The biggest reason is fear. And it's fear of, and then fill in the blank. Fear of being hurt worse, fear of dying, fear of your children being harmed, fear of your dog being harmed. Because people's pets are really part of their families. Fear of becoming homeless, fear of becoming jobless, fear of being stigmatized, shamed, outed, you name it. And when we come back for a full day, we'll brainstorm about what the different elements of fear are. But those are just a few of them. A lot of people don't leave because they don't have any safe place to go. It's safer to stay in a situation that they know is unsafe and try and manage within than think about where would they go. If I said to you, it's time to go, where you are is terrible, you need to go, where would you go? And you have all the assets. You have the financial resources. You're not being terrorized. How would you figure out where to go? And how to get your kids in school and how to continue to work? You may feel like a failure. I have a relative who, I'm on my second marriage, the practice one was not abusive, it was just bad. And the current one is, and it's the last one, is great. And in between, I had a relative that said to me, even though it wasn't abusive, the relative said, you know what, maybe eventually you'll meet somebody else and then it won't be a failure. Okay? And that's a good family. Okay? That's a family who's supposedly progressive and aware and this is my family. Okay? So people feel like they're failures. And they're told that they're failures by their perpetrators. You're a lousy wife, you're a lousy mother, you're a lousy cook, you're a disgusting pig, you're ugly, you're this, you're that, and the other thing. They really start to integrate that message. And I'm the failure, I can't do anything about it. You may be overwhelmed by this situation, you may have economic constraints, major ones. The perpetrator's behavior in the past may have been you tried to leave before and that person tried to kill you and said, if you leave again the next time, I'm going to succeed. You'll be gone. Or the person may have come with hearts and flowers and all kinds of things and I promise I'll never do this, and it was just a lapse. So again, on and on and on. There may be promises of change. A really strong one is the desire to help the perpetrator change. When good-hearted people see somebody who's done something wrong, the natural inclination is to try and help them. Right? We want people to be helpful. We want people to be compassionate. But this can get in the way of your own safety. And let's not ignore cultural and religious expectations or pressures, and also the fear of deportation now by coming forward. So survivors have to decide, should I stay or should I go? Okay? Or what to do about this situation. And very often you have survivors in your practice who are making a deliberate decision to stay until they can figure out how to leave safely. Okay? It's a deliberate decision. It's not a failure on their part, and it's not a failure on your part as a care provider as well. And leaving, we must remember, very often is a more dangerous choice than staying. So we shouldn't be trying to rescue people or telling them that they should leave. We should be trying to empower them with the information and the resources and the support that they can benefit from so that they can make safe and independent choices that work for their own lives. Okay? Leaving requires a lot of planning. I had a patient once who every penny that she spent was monitored by her abuser. Okay? She had to return receipts and change to the penny. She didn't have any of her own money. And what she did on the side, on her way walking the kids to and from school, was she was a binner. She would stop and collect deposit bottles that had been discarded and get a nickel at a time. And she opened her own little bank account on her own without telling, in her own name. It was the only finances she had, until she saved $320 in nickels, which was enough for a one-way bus ticket for her and her 3 kids. And she left. Okay? That's all she had. So sometimes leaving takes a lot of planning. And some survivors, though, stay until a red line is crossed and they say, I just, no matter what, I have to get out now. So we shouldn't assume that we know what anybody's situation is. And this quote, I think, is important. It's to understand why people stay. And this is an very upper middle class, white, educated woman. When I tried to get help, I was counseled to carefully consider how what I said might affect his career. And so I kept my mouth shut and stayed. I was told, yes, he was deeply flawed, but then again, so was I. And so I worked on myself and stayed. If he was a monster all the time, perhaps it would have been easier to leave. But he could be kind and sensitive, and so I stayed. He cried and apologized, and so I stayed. He offered to get help and even went to a few counseling sessions and therapy groups, and so I stayed. He belittled my intelligence and destroyed my confidence, and so I stayed. I felt ashamed and trapped, and so I stayed. Friends and clergy didn't believe me, and so I stayed. I was pregnant, and so I stayed. I lost the pregnancy and became depressed, and so I stayed. So the author of this is Jenny Willoughby. Does anybody know that name? Does anybody remember the name Rob Porter? Staff secretary in the White House, who's embroiled in all kinds of stuff now. I'm not getting political, I promise. This was his ex-wife. This was from her restraining order. Okay? This is not somebody else. This could be any of us. It could be any of your patients. All of the reasons I could give you lists, which you have, but this captures it all, just in one paragraph. But sometimes that red line is crossed. And the following are poor quality screen scrapes, because I actually took a Lawrence O'Donnell newscast at night, and he was talking about this at that time. And I thought some of these quotes were so amazing. I ran and got my phone, and I was taking pictures of the TV. So that's my extent of technology expertise. But here's somebody talking about why they stayed until. I tried to be a better wife, and I had babies, and I thought maybe I deserved it. And I thought because it wasn't constant and there was no lasting damage. Then he did it in front of my son, who was 8, and so I left. Okay? Sometimes that need to protect children is that red line that gets crossed. And again, that line can get crossed and produce further danger. So we have to be really careful about that as we care for our patients. Here's another one. The piece you read about Rob Porter's wife on why she stayed sounds exactly like what happened to me while married to my first husband. Thank God my dad rescued me. I married a great guy the second time around. So there is certainly next chapters for people. At 20, holding my infant daughter in my arms, he hit me in the mouth. She was covered in my blood. I looked at her and I said to myself, over my dead body will I give her a life like this. Left that night and never looked back. So very often it's either somebody who's important who says, I believe you, or something that happens that says, I cannot go back to this situation. We don't know until we ask our patients, and until we shut up and listen while they prepare, figure out if they feel safe enough to talk to us about it. And it may take time for them. So why don't they disclose to us? Again, the fear of all of those things. People may feel the healthcare system is not there for them. We see this in a lot of immigrants, not just those who are afraid of being deported, which includes, by the way, legal immigrants, a lot of them. But because the healthcare system in other countries may not be trauma-informed, compassionate, or on your side. And I've seen this in person in several developing countries where I've actually done field research on sex trafficking, some interesting work. But the government-run hospitals in a lot of different countries are quite abusive and quite stigmatizing. And so people who immigrate here and don't immigrate to get a PhD or some kind of higher job or education may actually not believe that the healthcare system is on their side. And that's one of the levels of trust that it's important for us to hear. They may be afraid of Child Protective Services referrals. They may not speak the language. My own daughter is trilingual now, and she is trilingual, but she said to me not too long ago, you know, Mom, when I was living in Barcelona, if something happened to me, I could go to the police and say, somebody stole my purse, or somebody hit me, or somebody mugged me. She said, but if it was domestic violence or sexual assault, I couldn't talk to anybody about it because I don't have the emotional language, because it's not my first language. And so we need to be really sensitive that people may not have the comfort with the language that they speak to you in to be able to disclose and feel that they're actually conveying the emotional nuance that they want to be able to convey. Their culture may say, you keep your own problems to yourself. Your culture may say, the greatest sacrifice in this life leads to the greatest reward in the next life. It may be. It may be that somebody's culture says, what's happening in your life is because of what you did in a prior life. This is your karma. Deal with it. Okay? There's a lot of reasons why people's cultures may actually interfere with their disclosing. Somebody who's trans, for example, or LGBT may not feel comfortable disclosing to you because they may think that you would look down on them for some reason. So there's lots of different reasons. Immigration we talked about, and abuser threats and control. You tell that doctor and you're not going to live to see the next full moon. There's a lot of specific issues related to the immigrant and refugee community. In no way do I want to give this short shrift, but I'm looking at the clock and I want to make sure we get to assessment and response. Please do pay attention to this slide as you move forward in your own education. So what's up with us? What are our challenges? Well, a lot of us never learned about this topic. I didn't learn a thing about it until 1987, when one of my medical students came to me and said, what are you going to do about this as a healthcare issue? And I said, I have no knowledge of this. I never learned about it. And it was a student, Steve Palter is his name. I'll put it out there on our recording. Wonderful guy. He's now an OBGYN in Buffalo. He's the one who woke me to this. A male, a medical student, and he woke me with a question. Okay? Many of us don't learn about this, and many of us who do learn about this learn about it from a talking head like me who disappears in your lives, and then it fades into the background as either an interesting or an ordinary talk. Okay? We haven't learned about it, and my problem with my medical students, I'm teaching still, not practicing, I miss it. My students say, but when we get to the wards, it's never talked about. And I say, that's right, because you're the experts now. You know more than your attendants. And so it's really important that we can never say again, I never learned about this. There's lots to learn, and I'm still learning, and I'm trying to retire. I'm an epic failure at that because there's still more to learn. You may not have the practical experience. And you don't need a whole lot. You need to have compassion and a phone number, basically. You may not know your local resources. You have local resources right here. You don't know what to do. You'll get better with time. I trust me on that one. You may say inquiry is somebody else's job. I'm so busy. Yep. We're busy. This actually may save you time. And if you think about your team, including the receptionist, the nurse, the medical assistant, the respiratory therapist, the community health worker. I'm pointing at Carrie and Mara because they're both employees here and they're both volunteer medical advocates at Center for Hope and Healing. If you think about your care team as a team, like a basketball team, you're always passing the ball to each other and playing one unified game. It's not one siloed person doing everything. So yes, it is somebody else's job, but it's also your job. And it's your job as the physician to make sure that the team is trained up and responsive. You may not have a private space to inquire or to act. That's a big one. If you don't have a private space, don't ask. Okay? You don't want to make somebody unsafe by asking in a public space. So my husband just went to his wonderful primary care doc the other day for, now that he's on Medicare, it's a wellness checkup. It's a nice thing. He's well. And he texted me a photograph of the form that he was filling out, like a little health questionnaire that he was filling out on a tablet in the waiting room. This is just 3 days ago. And so he said, look, it's happening. And it was a question about, have you ever been in a relationship where you were hit, hurt, or made to feel afraid by a partner? It's exactly from one of my slides. And I said, I'm really sorry that they're putting this on the tablet. And he said, why? I said, because it's in the waiting room. And an abuser can be next to you. Because very often they come and they monitor what you're saying and what you're doing. And if you put down no, because you're thinking about your own safety, you may actually be undermining the care that you might be able to receive. So we have to think about, when we ask, how do we ask, and is it safe? And you may have discomfort with the topic. Keep practicing. You'll get better. I'm sure that most of us have trouble doing rapid scales on the piano with our non-dominant hand. It gets better when you practice. So the dynamics for survivors is fear of always walking on eggshells. Is this going to be okay if I do this or that? The rules keep changing. They keep changing the rules. It's amazing. The erosion of independence, your world keeps getting smaller and smaller. You're losing friends, family doesn't call, text me when you want to call. You want to improve the relationship, not end it in general, okay? Especially younger people, they want things to get better. And you may feel that you're a failure and be suffering from chronic and recurrent health issues. On the perpetrator side, they may actually view their partner as an inferior adversary. She's no good at this, so I've got to make sure about that. He's a lousy whatever, so I've got to keep him in line. Okay? And I'm using male and female, and it's hard for me to use they because it's grammatically incorrect, but whatever pronouns you like, this is not just a strictly gendered thing. The coercive behavior is not a loss of control. And if you ever go to court and you hear a domestic violence case, and I used to take my class to court actually and have them sit in and listen, that's if you did an MPH. That was not in the medical process. Sarah's looking at me and saying, I didn't go. We used to hear all the time, I'm sorry, Your Honor, I just lost it. I don't know what happened. I have an impulse disorder. I lost control. No, this is about control. And I'll show you slides in a couple of minutes of a colleague whose husband actually wrote out in his own handwriting a 4-page list of what she needed to do to be a good wife and to not be in trouble or get punished. And this was in his handwriting. Problem was, he was a law student at the time, so he obviously didn't go to evidence class because this was actually used in his trial and helped him get convicted. So this is not an accident. This is purposeful, this is planful, this is designed to keep somebody in your orbit, under your control. And interestingly, a lot of abusers may appear healthier. So they go to court and the abuser is wearing a 3-piece suit or a nice outfit and is just looking very put together, and the survivor is distraught. And the abuser says, you know, she's got some mental issues, Your Honor. I'm really trying my best, you know, to help her. Because, you know, look, I mean, she's the mother of my kids. I love my kids, but look at her. She's a mess. And very often that actually works. Okay? And many perpetrators honestly do not see that what they're doing is wrong. They're not sociopaths with, you know, hairy faces and, you know, and white tank tops, you know, and tattoos who walk around looking like overgrown gorillas. They're regular people, like Rob Porter. Look him up. Rob Porter, staff secretary. Okay? He had a regular job, highly educated, highly successful, and highly abusive. And there's many, many cases like that. That's why, by the way, batterer intervention is so difficult and it's so important. And these programs take a year and they're co-led by 2 facilitators because they need the support of each other. And the first half of a batterer intervention program is actually focused on helping the group reframe the behavior as something they did and not something she did or he did in some cases. Okay? So so anger management, you know, 6 sessions, you're cured, count to 10, you know, punch the wall instead. That stuff doesn't work because this is not about anger. This is about control. Okay, I'm going to skip over this. That's the summary of the dynamics that we just talked about. So let's talk about clinical practice. Patients who come in who are being abused or who have been abused in the past and are suffering adverse health effects usually don't come in with that black eye or broken arm. They usually come in with musculoskeletal complaints, for example, back pain, headaches, abdominal pain, pelvic pain, recurrent sexually transmitted infections, eating disorders, injury sometimes, okay? They come in with that, and in terms of mental health, sleep disturbances, substance abuse, depression, anxiety, panic. These mental health presentations are now reconceptualized as adaptations to toxic stress rather than as diseases or faults. I'm going to talk a little bit about clinical evaluation and then about response, and I want to leave a few minutes at the end both for questions and also so that we can introduce our partners here. A resilience framework rather than a victim framework is critically important so that we're focusing on the patient's perspective and not on what our needs are. We need to focus on strengths rather than weakness, abilities rather than their problems, the future rather than past. Yes, you need to know what happened, but you also need to frame that in terms of what can we do to help you move to the place that you want to be. So trauma-informed care is a new buzzword. I think not only should individual clinicians be using trauma-informed care principles, but also the whole organization should become trauma-informed. It's universal precautions around lifespan trauma. You know, back in the day when I was in medical school and beyond, we never even used gloves. We didn't do any of that stuff. And it's amazing that I'm still here. But we always use gloves because you never know who's got Hep B, Hep C, HIV, or any other communicable disease. It's just something we do. Because even people who look perfectly healthy can actually have an infectious disease. So this is trauma-informed care is universal precautions around lifespan trauma. It's so prevalent that we have to just presume that everybody or anybody that we see may actually have been traumatized. And so we have to check in about physical touch during an exam, a sense of safeness if the door is closed, how to accommodate patients' individual needs. They're not just being squirrely or difficult, they're really having trouble coping in many respects. So take a look at that, and there are, in your resource list, there's actually a wonderful, you go to SAMHSA towards the end, Substance Abuse and Mental Health Services Administration. There's a wonderful document that's not too long to read about principles of trauma-informed care and how to incorporate that into clinical practice. But here are the principles. You model respect, you establish rapport and maintain it, respect professional and personal boundaries, share information. What I need to do next is X. Is that okay with you if I do X? Okay, so check in and expect that there are ebbs and flows. And promote safeness, which is a sense of internal safetude. In addition to safety, which is an external, your surroundings are safe, so you can feel safe. Feeling safe is safeness. So effective trauma work is trauma-informed, and it's patient-centered, and it's resilience-focused, and it's connected with local resources, and it's collaborative so that you can use your whole team. When you are inquiring, you want to ask from the patient's perspective, how has this affected your life and your health? Because there are people who you might want to reframe what you're doing because of the effect that it's having on them right now. Please avoid the urge to rescue the patient, because you want that patient to be able to make informed decisions that work for them. It's not your job to be Superman. And take care of yourself in terms of your own work-life balance. Now, inquiry is intervention. Every time you ask about this, you're actually changing somebody's life. Everybody remembers if they've ever been asked about this. It's not one of those, like, I can't remember if they asked if I used seatbelts or not. Everybody remembers. It's an enormously impactful event in healthcare, even if it only takes a second or two. How do you create that climate? You say, yeah, I don't want to just kind of ask out of the middle of nowhere. Use practice-based measures like buttons, Violence in relationships, we ask. Make up your own button. Or make somebody else make a button and give it to you. Put posters on your wall. Have tariff cards and resource materials in your office. Put them in the bathroom. People may not feel that they have license to take it in the waiting room, but they will disappear from the bathroom. There's ample research to show that. Write newsletters. There must be the Lowell General newsletter. Take it upon yourself to write a newsletter about this. Create a PSA in your neighborhood. Write an op-ed in your local newspaper. And set aside and manage your staff's time and responsibilities around this. Bring it up in staff meetings. Say, what do we do if we have somebody who the partner won't leave, or if somebody discloses, so that you have a routine and you can actually practice it. So we made this up in 1992, RADAR. Let's use your RADAR. Remember to ask directly, document your findings, assess for safety, and review options and make appropriate referrals. When I created this for Mass Medical way back then, I didn't say use your RADAR because I didn't think that would be catchy enough. But F, the follow-up, is also really, really important. Because once you do your work, if you say to the person, if you're comfortable, I'd like to see you again in 2 weeks so that we can talk about this a bit more. That message is come back. I value you, I believe you, I respect you. If you say, well, here's a card, here's a resource, good luck, that messages go away. So when you're inquiring, the first thing you should do is frame your questions by normalizing inquiry. And my students do this actually pretty well. And you can, anytime you see a check mark, it's something you could say. It's not required to say, but this is just part of your repertoire that you can choose from. Abuse, current and in the past, affects so many people, so I'm now asking everybody about it. Or so many people I see are coping with an abuse in a relationship, so I've started asking all my patients. So people don't feel like, what is it about me that you're like asking me that question? And then you can ask directly. Has somebody ever frightened you, threatened you, or hurt you in any way? Has somebody ever made you do something sexual that you didn't want to do, or when you were a child? So you can be asking questions, and it's pretty easy to ask. And again, use your own comfort zone for how you ask and what you ask. You can use indirect questions, and again, all of these are on your resource, on your slides. I like the last couple of ones. Are you able to speak your mind in front of your partner? Do you feel safe at home with your partner? If there was one thing you could change in your relationship, what would that be? That's an amazing question. It's incredible the answers you get to that question. Do you have to ask all these questions? Of course not. Pick whatever's comfortable for you in each particular situation, but do make sure that you ask about it. Yes, you can use written questions like the one my husband found on the tablet the other day. But please make sure those written questions are answered or are framed in language that the patient can understand and are exposed to the patient in a private setting. So if you suspect abuse, what commonly happens is you say, do you feel safe in your relationship? And the patient will look down, usually to the right, I don't know why, and say, my husband loves me. That's a yes to me, okay? So if you get a non-yes, I would love to be a congressional investigator, by the way. If you get a yes like that, but it's not the word yes, you can push a little bit and say, you know, when I see somebody with a situation like yours, very often it's because somebody's hurt her or him, or has done something else harmful or scary. Please tell me more. Those words, help me understand, or please tell me more. And then wait the deadly 7 seconds that you think is forever. Let the patient gather their thoughts. Let them frame what they want to say. Have your tissue box ready, and they will talk to you. Now, what if the person says yes? You're saying, I don't have time for this. I have 7 minutes for an encounter, right? If somebody told you that they were experiencing exertional chest pain for the first time, you would take 2 minutes to evaluate whether this is an emergency or not. That's a no-brainer, right? If somebody says they coughed up blood, you would take 2 minutes to figure that one out. This is the same thing. You can do a 2-minute triage and just say, what happened? Was a weapon involved? Tell me about the person who hurt you. Have your children ever seen you hurt? Are you in danger now? Do you need help from the police? The ones that are in yellow, and I don't know if they come across as any other color on the slide set, those are the big 3, okay? Those are the ones that will tell you, do I need to drop everything, ruin my schedule because I have a cardiac emergency, except it's not cardiac, right? You would never say, I'm not going to ask just in case the patient says yes, okay? And if the answer is no, and by the way, it's not usual that you'll have a yes, maybe once every couple of years like that, where you have somebody in acute danger. If the answers to this indicate to you that this is a problem, but it's not an emergent lethal problem, then you can say, I'm so glad you told me about this. This is so hard to talk about. What tremendous courage you have. Can we meet again? I want to devote a whole meeting to this so that I can learn more from you and figure out ways that we can work together to help. Is that okay with you? Okay? And so when you see the patient in follow-up, there's all kinds of questions that you can ask, and I'm not going to go through them, okay, because they are there for you to look for on your own. There's 3 slides of them, I believe. But what's important is you want to know how people are coping. Do you cut yourself? Do you space out? Do you get drunk or high? Do you do any harming behaviors? Have you ever thought about suicide? So again, take a look at these questions on your own at your leisure, and feel free to ask any questions of me or your colleagues at any time. So physical findings. Look for any injury. Injury is not that common in domestic violence, even though we use the word violence. But any injury, especially injuries that are bilateral or multiple, or that there's an inconsistency between the history that you're able to obtain and the injury pattern that you see. And frequent use of emergency services. That may just be the lack of primary care, although I've met a few wonderful primary care docs here already today. Send them new patients, even if they say I'm closed. Just say, take one more. If you have any chronic pain symptoms, a pregnant woman with any injury, or a partner who's very protective, I want to make sure you do the right thing, doc. I'm going to make sure every single thing that you say is the right thing for my wife. Okay? That's a warning sign for me. That's not devotion, that's control. Why should you document? It's the right thing to do. Medically, it's the morally right thing to do, because you don't want to leave that out and not have that information available for your colleagues. It may keep you out of court for a criminal or custody case. A lot of us say, I don't want to put anything in the chart because I don't want to wind up in court. Believe me, if you have good stuff and it's non-judgmentally framed, and I'll go into that in 1 minute, the defense will take a look at that and say, oh, there's no way we're going to win, settle. It will keep you out of court, I promise. And it may actually keep you out of court for a standard of care issue. So you can have written descriptions, diagrams, or sketches, or photographs. This is the extent of my art. This is not even my picture. But you can put on a stick figure or on a diagram like this areas that are swollen, areas that are erythematous, areas that have just pain that won't show up on a photograph. So I actually use a figure like that. The reason I say this is the extent is my daughter's an artist, actually, and I don't know where she got it. Obviously not from me. This is these, for those people who are looking at this on the streaming, you will see this, but on the archived presentation, the next 5 slides will be blank because I don't have permission from this survivor to share her slides. I do have permission to use them in my teaching. She's a pediatric dentist. This was taken a while ago. I don't have time to go into her story, but just in terms of documentation, there's a photograph of her showing the injury, which is just an ecchymosis, but it's very impactful in a courtroom setting, or for anybody who's not medical. And it also shows the person's face, and it also has something that has the date on it, so that you can say, I took this photograph of this patient with this injury on this date. Okay. There's a close-up of the injury, obviously a superficial injury, and creates gasps every time I show it to anybody who's not a medical audience. It's amazing. The stuff that we think is nothing, because actually this is not much in terms of injury, can be enormously important in a court of law or in training. This is, you can see that there's an ecchymosis on her chin. That's from the same assault. So you see multiple injuries in different places. You can see this in this slide. She's standing in her kitchen, actually, and she's holding up her forearm. I'm just describing it for the archived version. And it's a poor photograph, but it shows defensive injuries on her forearm from trying to actually block blows to her face. And this final picture is of her and her then husband, the one with the 4-page list of things she needed to do to be a good wife. She has a black eye, and that's from a different incident. You can see that. That's from a separate assault. And he has black eyes too. I put them on for my protection. And they're at a cocktail party at the home of the judge that he was serving as a clerk for. And nobody asked. Nobody said, I see you have a black eye. Are you safe? Are you okay? Okay, intervention. What's the risk? Well, ask the patient, do you feel you're in danger? And then use your own assessment. Is the abuse getting worse? Are there threats of homicide or suicide? Is a gun available? Does the abuser know that the victim is planning to leave? And here are your roles. Communicate concern. Assure confidentiality. What you say to me will not go back to your partner, will not go anywhere unless you have legal requirements, for example, a child, elder, or a disabled person. Provide information, review options with the person, and liaise with your community advocacy organizations. That is so crucial. Medical treatment and follow-up, you can do that. You'll do that. But the other stuff is actually more important. This slide, again, anytime you see a check mark, is examples of the kinds of things that are really helpful to say. Validate your patient, communicate empathy. Thank you for sharing this. You're not crazy. You deserve better. Things like that can be life-changing. Say, I care about you. You can come back here at any time. Assure the confidentiality. As we talked about, provide information. Again, I'm racing through this because I'm looking at the clock. There seems to be something wrong with the clock. Provide your information. Offer resource referrals for safety planning, for support groups, legal services, social welfare services, et cetera, and so forth. And this goes beyond just the injury. This goes for things that can help somebody become independent in their own life. Safety planning is a process. It's not a thing, okay? It's something that happens over time. We're not so good at it. Advocates are really good at this. You can start the process, but it's an advocate, and that's why that connection is so important. These are some of the components of a good safety plan process. And follow up. It gives people support and credibility. Okay? Can't believe I got through almost 75 slides. So here's your RADAR acronym. But there is more, because there is 1 minute left. You are respected in the community. You are a valued team member. You can actually make change happen, not just in your own practice, but on an organizational level. And there are lots of opportunities for leadership and scholarship. There's tons of room on this bus. So people who are interested are more than welcome. And these are some of the things you can do. I put in a slide for the social ecological model for anybody who has a public health interest, and thinking about not just the individual actions that you can take and also that underpin this issue, but relationship, community, and society. The social ecological model is so important. It's a key pillar of public health. I was giving a talk on human trafficking. This was 2012. And this woman comes up to me at the end to ask a question. And I noticed the tattoo. I always look at people's arms to see, like, are they okay? And I said, that looks like the social ecological model. And she said, it is. She said, it's my guiding light. It's so important. I had it tattooed on me. Okay? I'm not suggesting that. But that's how important that is for public health. And I have just 3 more slides. This one is from Dilbert, as you can see clearly in slide 397, and the guy in the middle keels over. And you have just witnessed and experienced another case of PowerPoint poisoning. So thank you, and please don't hesitate to reach out. Our community resources is somebody from Alternative House. Actually, yay, you're here. So what's your name?
Kylie.
Kylie from Alternative House, which is our local partner for domestic violence, and also Mara and Carrie, who are also employees here, who are medical advocates for the Center of Hope and Healing, which deals with rape, acute and follow-up rape crisis and sexual assault prevention.